Oh, when you can. Is that yes or no?
Yes.
Yes, okay. Thank you.
The ones down here can hear better. How about you? Over here?
That's working all right?
Yeah.
Okay, well if I fade out, wave.
You just have to speak into it.
Okay, good, thank you. Well, it's a real pleasure for me to be here. As you might guess, I've always enjoyed talking with people from the league. I've always felt I was part of the league, and that begins with my early professional work here in Utah. We had a sort of changing or evolving description of what I was going to cover. I was never quite sure how it was evolving, but every time I saw a notice, it was slightly different. Now that didn't worry me at all because I didn't intend to talk about it anyway. That it was, it tended to focus on providing you with an update as to what's happening in Utah with the Affordable Care Act. And I'll say something about that because that's a good introduction to what I would like to talk about, which is where things are headed in health reform and what that means to us as individuals and to people interested in public policy. There are two issues right now regarding the Affordable Care Act that the state is facing directly, as you well know. One has to do with the exchange and the other has to do with the expansion of Medicaid. I'll take the exchange first. And by the way, in my present role at the university, I'm paid nothing and I sometimes do nothing. And because of that, I can be quite free. It's clear that I'm talking for myself and not for the university. And so especially, now if I was meeting with my siblings, I'd have to be more careful, but with the league, I don't need to hold back. Now, on the exchange. I don't think Avenue H is going to go very far. It may survive for a while, may survive for a long time. It may be absorbed into something else. But in terms of what was originally intended, I don't think it's going to accomplish that. The idea was that a big part of the problem for small employers is that because they're small and just have a limited number of enrollees in an insurance plan, that it is very difficult to spread the risk. And therefore the charges for insurance tend to be quite high for small employers. This is the third time that I'm aware of, the third time in my time here in Utah, that there's been an attempt to solve that by providing some kind of an organization that could pull together a number of employers and with that have a pool that offered more opportunity to share the risk. Both of the other two efforts were well led, and the first one had some national financing. I forgot, from one of the large foundations, forgotten which one now, but both of them failed. And it's not hard to predict that they would fail because it is very difficult to bring together enough of these people that you really can have a shared risk. Well, the Avenue H has an advantage, and that is that it has a state sponsor, and in that can handle some of the financial difficulties. But it is still not easy to have enough enrollees that you're able to offer a rate that is really affordable or competitive with other things, in spite of the fact that there could be some state subsidy for it. The state program, the state exchange, is very different in purpose than the proposal in the Affordable Care Act for exchanges for every state. The purpose of the exchange in the Affordable Care Act is to provide a mechanism for individuals to find an affordable kind of insurance with significant subsidy from the government. Their primary purpose there is to provide a way that individuals who are not otherwise covered can find affordable insurance, and in effect the government's willing to pay a substantial subsidy so that it is affordable in this market, which is so difficult in the small market. The state program had quite a different purpose, and it was to reduce the cost of health insurance for the small employer. And so it particularly looked at the idea of moving from a guaranteed benefit program to a guaranteed contribution, which shifts from the employer to the individual the burden or responsibility of managing the cost. And it allows the small corporation to control the cost however they decide, and then just give that contribution to the individual, who then must supplement it in order to be able to afford whatever insurance is available on the exchange. Well, as you probably know, the enrollment is still very small. The governor has just recently shifted the fellow who was responsible for this out of his office to the health department. He was originally in the health department, and the governor sort of captured and brought it into the governor's office. But I see that as an indication of declining enthusiasm for the future of our exchange. Now, whereas I don't see much future for Avenue H, which is what our exchange is called, there are a couple of things that came with it that I think do have a future, and these have to do with data. One is the all-payer database, which is a collection of data so that you can, for a particular person's particular condition, keep track of all the costs that are being incurred for that condition, for that person, which gives us far more information about what is being expended and how much variation there is in that expenditure for particular conditions, how much variation that might reflect geographic location or might reflect the provider or whatever. Anyway, it's a far richer source of data than anything we've had. And Utah was one of the first states to get into it, was well ahead, and it has momentarily collapsed. It collapsed because the state contracted out the major management of the data. The state has the data, but in terms of managing it, they contracted it out. And private sector as well as public sector tends to promise more than they can provide. And the public sector, when that happens, what we do have is cost overruns. In the private sector, we have bankruptcy. Well, this was a private sector instance, and the company has now gone bankrupt. So we need to start over on that in terms of finding a new contractor and specifying it more reasonably. The other data is what's called the CHI, which stands for Clinical Health Information Exchange. Again, Utah was in the lead on that, but it has somewhat disappeared recently, and I'm still trying to find out what's happened to it or where it's buried. I think what's happened is that some of the providers have balked at the administrative burden of handling this, because there was a key issue of whether or not, let's see, I'll say something about what this is. This is a network so that wherever you might be provided with health care, say you're down in Moab and you have an accident, that the physician there can get on this network and can immediately, this is with your approval, can immediately then tap into your full medical record in order to provide you with better care. And when you come back, they can hear, your physician here can immediately tap into what was done in Moab, so you don't have to redo the tests and so forth. It's an opportunity to substantially improve the care because you can more immediately act because you don't have to redo the tests and so forth because you have a more complete record. And it's also an opportunity to save costs because you don't have to duplicate it. But a key question here was whether or not individuals could stay out of it. And there was no question they could stay out of it. But then the question was, well, how do they decide to stay out of it? Do they opt in? That is, unless they agree to go into it, they're not in it and it can't be used. Or do they opt out? That is, that everyone is presumed to be in it, but anyone can opt out of it whenever they want. As you might guess, that was a major issue. It has lots of questions about privacy engaged in it. One of the things that we were able to show here was in the early days as this was going on, this was within the last 2 years, we were able to bring together the Health Information Exchange people and the ACLU to talk about it in advance, rather than to wait and see what happened and then see if the ACLU wanted to raise a question about it. I talked to a friend of mine in Chicago who does a lot of the same kind of thing that I do here, and he said that would just be impossible. You'd be a fool to even suggest in Chicago that you could bring people together to talk about things like that, but it's possible here. Well, because of that discussion, what was accepted was an opt-out, no, an opt-in, wait a minute, an opt-in kind of system, so that you're out of it unless you have decided to join in it. Now, the problem with that is that it much more clearly protects privacy. That's not the problem with it, but the problem is that there's more administrative work in terms you have to explain to people what this is about, so they'll decide to opt in. On the other basis, they're just in, and they have to decide they don't like it and then try to get out of it. The providers have, I think, been reluctant to make the investment at the front desk of offering this choice to the people so that they can decide what to do. Well, in both those cases, Utah was 2 years ago among the most forward states in the country. And at the moment, they're a bit stillborn. But I have hopes that we will still be able to move them both. Now, on the Medicaid expansion, there's no question we should take it. Did you need some? Okay. Leanna just asked me if that meant I didn't support charity care. So I didn't know she needed it. You do have to be careful in terms of how this is reported in the paper. The Tribune has a terrific health reporter, but last week when she was explaining this, I thought it would easily confuse people because it talked about how much the growth in Medicaid would cost the state government. Well, it's because she was inflating two different things. One is the expansion of eligibility for Medicaid, which is what the issue's about, and the other is what the people in Medicaid call the woodwork effect. That is that we have a large number of people in Utah, this is common around the country, although we tend to have more.